Yes, and good afternoon, everybody. My name is Dr. Maad Al Saati. We're going to start our session. It's about the ACL debate, and we're going to start by an icon in orthopedic surgery, Dr. Bruce Reider, who's from the United States. You are more welcome to start.
Greetings to all my friends from EGAA. It's great to be back here again and see all my Egyptian friends and have the opportunity to share with you my perspective on ACL primary repair in the 21st century. Are we going back to the future or only back to the past? I think to understand the place of ACL primary repair in the 21st century, we have to talk about the 20th century a little bit. And for me, this goes back to this monograph, which appeared in 1938 by the Swedish author Ivar Palmer. This was really a small book. It was part of the Acta Chirurgica Scandinavica, and it had everything you wanted to know about the ACL and the other ligaments in the knee, and became kind of the reference point to many surgeons who wanted to know how to repair the ACL, because as Palmer observed, it would rarely heal spontaneously. So he described methods of repairing the ACL with multiple sutures, and these methods were picked up by a few of his acolytes in the succeeding generations. One of these was Dr. Don O'Donoghue. Dr. O'Donoghue was the first president of the AOSSM, and he's often referred to as the father of orthopedic sports medicine in the United States. And he published this paper in the Journal of Bone and Joint Surgery in 1955 of his series of ligament repairs, especially involving the ACL. And he used suture techniques similar to Dr. Palmer's. Now, Dr. O'Donoghue was head of sports medicine and orthopedics at the University of Oklahoma. So for him, most of his patients were American football players. His follow-up was short-term, and success meant the ability to return to at least one game of American football. Let's go on to a slightly later generation, Dr. John Marshall at the Hospital for Special Surgery, with whom I had the opportunity to work as a fellow in the later 1970s. And Dr. Marshall often referred to Professor Palmer and used his methods with multiple sutures to meticulously repair acute ACL tears, no matter where in the ligament the tear occurred. And he published his 2-year results, and they were quite favorable. Unfortunately, Dr. Marshall was tragically killed in a plane crash at the age of 40 in 1980 and was not able to report his longer-term results. But another colleague and friend of Dr. Marshall's, a contemporary, was Dr. John Fagan, who was the head physician at the U.S. Military Academy at West Point. And he also believed in ACL repair and did a very similar technique. And he reported his 2-year results at the American Academy of Orthopedic Surgery, and they were quite favorable. Unfortunately, he continued to follow his patients, and in this very well-known paper by Fagan and his colleague Walton Corll, they reported the 5-year results, and they unfortunately noted a marked deterioration of the results between 2 and 5 years. So this really brought attention to the fact that 2-year follow-up was not really sufficient to determine the success of ACL repair, and it also directed people away, especially in the U.S., from doing ACL repairs. But there were other studies that also seemed to shed a bad light on ACL repair, like the one on your left from Sweden, from Odenstein, Gilchrist, and Lysholm. They also followed their patients for 5 years, and they also noted a deterioration in the results between 2 and 5 years. And then finally, the randomized trial that Mr. Arbuthnot referred to earlier today, that was first published in 1990 by Lars Engebretsen and his Norwegian colleagues. And they had 3 groups: a primary repair group, a primary repair reinforced with a ligament augmentation device, and finally a reconstruction group. And they've reported this at multiple time intervals, and always the reconstruction group has done the best. So the attention really turned to reconstruction at that point in most parts of the world. This was nothing new, going at least as far back as 1920, when the British surgeon Hay Groves described reconstructing the ACL with a strip of iliotibial band. Well, on your left here is an important paper that I think is forgotten by most people, or maybe they didn't even know about it, because in 1963, a little-known American surgeon from Arkansas Kenneth Kenny Jones described using the middle third of the patellar tendon to reconstruct the ACL. Not too much attention was paid to this paper in the US, but more attention was paid in Europe, where people like Einar Eriksson in Sweden and Kurt Franke in Germany did patellar tendon ACL reconstructions. Finally, in the early 80s, Bill Clancy at the University of Wisconsin published his results of patellar tendon reconstruction, and this became so popular that for a while, patellar tendon was known as the gold standard of ACL reconstruction. Moving on, though, some surgeons challenged the gold standard, particularly Australian surgeons such as Leo Pinchevsky and Julian Feller, who showed that they could get as good results using hamstring technique with less problems such as kneeling pain. And of course, this led to techniques such as the double bundle reconstruction discussed earlier today. But not everybody was willing to leave the idea of ACL repair because it just seems to have a certain romance attached to it. And this paper, which was referred to earlier today by Mark Sherman, appeared in 1991. Dr. Sherman was Dr. Marshall's last fellow before his untimely death, and he published his results of ACL repair. And importantly, as you see in the upper left-hand corner of your screen, he noted that tears that occurred at the proximal end of the ACL seemed to be the best for ACL repairs. So this is something that's been noted by current techniques. Well, let's move on to the current day, because still people are pursuing the idea, the quest of trying to have a successful primary repair. But the question is, are we like the mythical knight Don Quixote, jousting with windmills, or are we actually going to something that could be successful? Well, there are 4 techniques that are currently popularized for ACL repair today. And the first is really a hybrid technique. It's remnant preservation. So in other words, doing an ACL reconstruction, but also repairing the ligament and incorporating the remnants of the ligament to it. And this has been favored by a number of surgeons, notably Professor An from South Korea. But although this seems to have the promise of perhaps enhanced healing and preserving proprioception, the clinical differences from using this technique have not been that marked. And in fact, at the bottom of your screen, you have a randomized trial that was done by Hua Feng and his colleagues from China and published in AJSM a few years ago that compared primary reconstruction with remnant preservation and didn't show any advantage for remnant preservation. But you might say, well, that's really not ACL repair, that's just kind of enhancing a reconstruction. But there are at least 3 techniques being promoted today that do an isolated ACL repair. And it's been already mentioned today. One of them is by Martha Murray, a surgeon at Harvard in Boston. And Dr. Murray's been working on this technique for many years, as you can see from this prize-winning paper from 2009, in which she first performed her technique in animals, in fact, small pigs. Now, the illustrations at the bottom of the screen here show her technique, and it involves doing a primary repair of the ACL, even in the mid-substance, and then using a biologic sheath around it to enhance healing. And she's progressed to the point of doing this in humans. Last year we published her two-year results, the first in-human study in a small group, and again at 2 years this seemed to be successful. And I can share with you that she has another paper coming out in the next 2 months in AJSM that actually is a randomized trial of 100 patients of the same technique, with 50 of them being allocated to primary repair and 50 of them to primary reconstruction. And the primary repair patients did just as well as the reconstruction. But again, only 2-year results. Let's move on to another technique, the meticulous repair of proximal tears. This is being promoted by Greg DeFelice, who interestingly is at the same hospital as Dr. John Marshall, who I mentioned earlier. And interestingly, he's also using very similar techniques of multiple sutures through the ligament. And he is observing the advice of Dr. Sherman and mainly restricting his technique to proximal tears, as you can see over here. Well, he's reported his early results with 11% failures at 3.2 years. and he started using the internal brace in his later cases. And although he doesn't have enough to prove it statistically, he feels that he has better results with the internal brace. But not everyone has the same success with this technique. This is a paper that we published last year from the University of Colorado. Now, it was done in a very challenging group of patients, 22 children and adolescents, the ones most likely to have failure of ACL surgery. And these authors did 22 primary repairs. They used suture tape augmentation, so-called internal brace, and they compared them with quadriceps tendon reconstructions that they'd done in a similar group of patients earlier. And they were a little bit alarmed because after 3 years, there was 49% failure in the primary repairs compared with only 5% failure in the reconstructions. So they were not very enthusiastic about continuing with this technique, at least in this group of patients. Now, interestingly, this paper caused Gagliardi to get a letter to the editor written by De Felice from Special Surgery. And in this letter to the editor, De Felice said, well, maybe we should change our criteria for judging success or failure of a primary repair, because a primary repair is much easier to redo than a reconstruction. But Gagliardi replied, and I would tend to agree with his opinion, it may be easier for a surgeon to redo an ACL repair, but from the point of view of the patient, they've still had a failed operation and they've gone through maybe a few years of rehabilitation and trying to get back to play and then re-injuring themselves and maybe lost most of their short amateur athletic career. The final technique that I wanted to talk a little bit about is called dynamic intraligamentary stabilization, or DIS. And it's been described by a group from Switzerland, Professor Egli and his colleagues from Bern. And it uses this device, that's sort of a spring-loaded device. So it takes some load off the ACL and it has a little bit of give to it. And they've published several papers showing pretty favorable results. First, in 2015, they had 278 cases, but only 12-month follow-up. They had very good IKDC and lysome scores. It's probably worth noting, however, that the Tegner level of these patients was only 5. With that, they had 11 failures, only 4%. Their later follow-up in 2018 with even more cases and longer follow-up of 2.5 years had 8% revisions. But a little bit worrisome is the fact that they observed that patients who were younger, less than 24, or had a higher activity level, Tegner greater than 5, had greater post-op laxity and more failures. Now, their results have been duplicated by other investigators. Last year, we published this randomized trial by this group of Dutch investigators. Again, it was 2-year results. They compared this DIS technique with a 4-stranded semitendinosus reconstruction. Both groups had very high IKDC scores, and if anything, there was a tendency to fewer re-ruptures in the repair group. And I can tell you in the next month we have another randomized trial coming out in AJSM. This one is from Germany at the bottom of your screen. And again, the 2-year results show comparable clinical results from ACL repair. Although maybe a little bit worrisome is the fact that they noticed about 1 millimeter more average KT1000 anterior tibial translation in their repair group. Again, not everybody has had these good results. This paper from an Austrian group appeared in KSSTA last year, and these authors had 59 cases with a mean age of 27, so not even that young. And they were alarmed to find 18% failures at 1 year, and even more worrisome was the fact that almost half of their patients had a KT1000 side-to-side difference of more than 3 millimeters, and about a quarter of them had a difference of more than 5 millimeters, which doesn't bode well for long-term follow-up. So my conclusions for you today would be, primary repair of the ACL certainly retains an attraction that has led to recurrent interest over the years, but I will also remind you that historically, short-term results have been good but often deteriorated with longer follow-up. The current approaches include ligament remnant preservation along with reconstruction, but this has not really shown major advantages. Then there's the bridge-enhanced ACL repair from Martha Murray. This is favorable, but it's only in those early stages of investigation with only 2-year follow-up. And then finally, we have those other 2 techniques that I described, the meticulous suture technique from Professor De Felice from the Hospital for Special Surgery. And he reserves this for proximal tears and has noted that adding an internal brace may help these results. And then finally, the DIS technique with the originators and some others reporting good results. But I would remind you, for each of these techniques, as I told you, there are divergent results reported by some, especially in young and more challenging patients. So my final recommendation to you would be to wait for longer-term results from multiple investigators before replacing reconstruction with primary repair in your practice. And I was very encouraged to hear Professor Mohammed's presentation today, and I think that will be one of the investigators that will tell us whether this is something for general use. Thank you so much for your attention today.
Next speaker, Dr. Maad Al Saati from Saudi Arabia. I think cooperation between Italy and Saudi Arabia for graft link for ACL repair.
Thank you all for being here, and thank you for the invitation, Professor Adel, for that. Okay, and excuse me for my lecture, but because I was just informed to be presenting this morning. And my name is Maad Al Saati. I'm an orthopedic consultant. I do my I'm on behalf of the Saudi Orthopedic Association, as well as I work in Princess Noura University, and my private work in Saati Medical Center. This is where I work. It's Princess Noura University, a new hospital that has been started just 5 years ago. And today we're going to be talking about the graft link or all inside technique introduction, graft choices, graft link advantages, adjustable loop, and effect of graft size. So as everybody knows, the all inside technique, it has been known for a long time right now, more than 20 years ago. It has been ups and downs, and our purpose of my presentation was to address some of the unique elements in ACL reconstruction and compare it to the old technique that has been everybody's using nowadays. So in the ANA and the AOSSM, okay, all the updates about the graft choice everybody's using nowadays is the hamstring tendon, and the BTB is still the gold standard for everybody, especially for high athlete and high demand. The technique is very well known for everyone. It's the anterior medial portals that has been doing, but and still some people are doing the other techniques. So the evolution of ACL reconstruction has been, everybody's talking about it right now, how we were before in the past. We were doing the transtibial and then going to medial portal techniques, medial portal with screw, now medial portal with cortical fixation. So ACL has been changing all over with the time, which is very good and right now. And going further for the biomechanical evaluation using hamstring ACL reconstruction. This was on a cadaveric studies on 2010, and it shows that the hamstring can restore the anterior tibial translation as well as reproduce similar rotatory and torque properties. And another clinical study compared the standard ACL technique using quadruple semitendinosus tendon or for ACL reconstruction versus BTB. It shows literally reported that there was no significant differences between them. The only thing that we are having and we're facing over here, especially in Arabic population, is that we're kneeling forward while using the BTB and causing more knee pain anteriorly. Single hamstring versus semitendinosus with the gracilis, it gives you more options, such as you can choose the size. You can whether size 8, 9, 10, as much as you can do. and less less pain as well, and you can still have the anterior torque of the with motion, and you can preserve the gracilis as well for other purposes, such as ALL or a posterior lateral corner, or as well extra-articular tenodesis. On inside as well, it's an autograft that we are taking from the body. It gives us the opportunity to have cortical fixation on both sides, femoral side as well as the tibial side, and it's closed potted tunnels to preserve the synovium as well, and decrease the operative time, and independent outside in drilling, medial evaluation, longer femoral tunnel. You can choose the length of the tunnel as much as you want, and less risk of blowing the cortex specifically in femur. Talking and any type of adjustable loop, not specifically in this company or any other companies, okay, it has the better chance that you can have 4-point knot locking, and as well as the best part in the adjustable loop that you can as well address the graft. You can manipulate. You will not have a space between the bone and the graft, as you can see over here, specifically with this study that has a biomechanical evaluation of adjustable loop suspensory anterior cruciate ligament. It shows over here, whenever we are looking to this area over here, this is whenever you're using a rigid loop or you putting your button, you always sometimes have a space between your graft as well as with your bone. Whenever you have an adjustable loop, you can have bone to tendon contact, specifically in the femur and as well as in the tibia. And the ability of retensioning after cycling the knee is much easier. Whenever you cycle the knee, you still feel there's still some loosening. You can still tension your graft. Only for adjustable loop on both sides, as well as to avoid loosening sometimes, because this is the trend that everybody is talking, and this is why everybody doesn't want to do an adjustable loop sometimes, is that they are afraid of loosening post-operatively. The trick how to avoid that is to do a simple knot, usually at the bottom of your graft. Simple knot, as well as I was talking to one of my colleagues yesterday, I learned from him yesterday that if you want to do a knot on the femoral side, you can use the shoulder, the knot pusher as well, and you can insert it directly at the femoral side. So you can do knot in the femur as well as on the tibia to avoid loosening from both sides. Another biomechanical study testing using the adjustable loop. Why is it better rather than using screw nowadays? Is that the adjustable loop retensionable suspensory fixation gives you more femur and tibia opportunity to improve the biomechanical action, okay? Whereas doing it with, whenever you're doing it, applying a screw and you're cycling your knee, sometimes you might have loosening. You want to have to remove the screw, retention one more time. You're widening the tibial side. So this is the thing that we are trying to avoid it nowadays. As you can see over here, retensioning with the screw fixation, 64% less of intra-articular tension after cycling, and sadly you cannot do anything right now unless you remove your screw, and this moment you are widening your tunnel as well. The anterior translation increases 1.1 millimeter to 2.7 millimeter after cycling. Another comparison study over here, why to use adjustable loop. Why? Because you have four sides bone to tendon contact. It's not only 3 sides, okay? Other than that, within 2 weeks to 12 weeks, you can see really the bone integration into the bone graft. The osteocyst and the osteoclast are integrating into the graft and has more rigid fixation and faster recovery. And comparing screw to cortical fixation, it has a better histological integration then. And honestly talking, okay, the biology is the same, but still the cortical fixation, for me personally, I think it's much better and much easier to address it. And tibial fixation using the biomechanical testing, the greater ultimate load to failure and greater force to displacement versus interference screw. Because whenever you are applying screw, it happened with me, and I think it happened with somebody else, that sometimes your graft is looping around your screw and rotating. This thing, whenever it happens, okay, this is going to weaken your graft. You are manipulating and jeopardizing your graft. We have one graft to use. We cannot use both graft, both legs. So it's the first chance, the best option is to apply it once and then try to tension in one direction. It's going to be much easier for everyone. Other rule that plays an important for avoiding any failure, the bigger, the better, okay? Over here, it's a clinical study that shows that your graft, if it was less than 8 millimeter, that means your graft is jeopardized for failure, or the percentage of failure is more higher. So that's why our goal every time is to augment our graft, and especially in athletes that they want to go back faster and they want to have their real life easier. So another graft size potentially, whenever another study that shows that if your graft size is between 9 to 10 millimeter, the better outcome and less failure rate. As well as whenever you are having a bigger graft, okay, from 8 and above, okay, you are more prone to have hit the target and greater footprint coverage. So try to avoid most of the time, okay, having smaller graft. You say this is what he has. No, there's another option that you can improve yourself and have better outcome. Autogenous graft size as well. Okay, the larger variability. Okay, the bigger the athlete is. Okay, the bigger the graft will be, because especially the one who are using their hamstring more and more. The shorter athlete, the smaller, the petite athlete, okay, they are more prone to have 7 millimeter. Okay, he has an ACL tear. Should I give him a 7 millimeter only, or I can improve it and give him something else? So this is your time to augment your graft and give him more bigger graft. Graft of 8 millimeter or less, as I told you, is less prone to have revision rate. As we heard this morning, okay, what should you do? There is always an augmentation or a graft augmentation. I totally believe in it, and I think I've been doing it for my athlete and have very good outcome. Is the internal brace or augmenting your brace from any company, but at least it has a very nice biodegradable and biointegration and gives you a more better strength. Because sadly, our people, when you tell them not to go back to sport before this period of time, he thinks that he's fine and he can go back anytime he wants. So all inside technique comparing to our traditional, okay, it has less pain, faster, and there is no difference in outcome, honestly, according to the literature. It has similar KT1000, suspensory in the IKDC is 100%, as well as a re-rupture rate is almost equivalent depending on the size, graft size. A graft failure with anatomical femoral tunneling, okay, whenever we are having it, whenever we're having inside out, we are more prone and more easy to adjust our tunnel and to know where we are directing, especially behind the resident ridge. And whenever you have a bigger graft, you're more easily to directing it. So in summary, single hamstring tendon is a good option. You can preserve your other tendon for other things. All inside grafting technique is a good option as well, but it needs training. I had difficulty at the beginning. Large graft in diameter, decreased amount of post-operative pain, as I mentioned, and your scar is going to be smaller as well. Minimal invasive socket on bone preservation, and stronger adjustable cortical fixation, which I think it's going to be a good option specifically for the revision cases when you want to do it. And there's another presentation that I can give it later on. It has, as I told you, we are preserving the synovium. We are not leaking. We don't have a leakage, specifically whenever you're doing with your lavage and everything. You can see all the synovium is going out, all the bone graft is going out. So it's very nice to protect it. Single side knot in the tibia, and yesterday I learned from the femur, and as well as it's give you a better outcome for all patients. I'm done with my presentation, but I would like to continue with one thing. I would like to welcome you all to Saudi Arabia. We had the opportunity to host the Asian Federation of Sports Medicine last year, and it was a successful presentation. And in 2018, we had, for the first time as well, the first knee conference that was done in Saudi Arabia. It is only dedicated for knee only, hosted by my father, Dr. Fazal Ali, and me personally. It was done in Princess Noura University. We had 2 days, arthroplasty day and sports medicine. It's specifically just for knee, directing to all medical field, local speakers, international speakers, and CME hours. And our next meeting is going to be this year, inshallah, and everybody is more than welcome, 16, 17, 18 of October. Welcome to the knee.
I believe our next speaker is going to be Mr. Neil Jain from the United Kingdom, talking to us about ACL in the elite athlete. I hear they have some in the United Kingdom.
I'm sorry. Okay, lovely. Thank you. So you just point. Oh, and it comes up there. Thank you very much. Well, brilliant. Thanks very much. Thank you, Professor, for the introduction. It's a pleasure to be back. I was here last year, and it's a big thank you to the EGAA for inviting me back. I don't think it's me that's being invited. I think I'm here representing BOSTA, the British Orthopaedic Sports Trauma and Arthroscopy Association. You can follow us on the Twitter at BOSTA_UK if you so choose. But it's a pleasure to represent BOSTA and to be here on our behalf and growing our affiliation. I like to think I might have done something good last year because I was asked to be a world expert in how not to do an ACL or how to do it wrong. So I think my topic this year has suggested I might have improved really in that time. It's going to be a very non-scientific whirlwind tour, a whistle-stop tour about how I deal with the elite athlete, how some of the challenges that we have with an elite athlete are there, and how that may differ or be consistent with what we do with a non-elite athlete or just Joe Average on the street. It's a very famous elite athlete from the UK who tore his ACL in the FA Cup final of 1991, and this sits very badly with me because you'll see the chap he's tackling in the red. He plays for a team called Nottingham Forest, who's my team, and they haven't won very much ever since this game, so that's bad. So in terms of frequency, now it's something, ACL injuries, we see a lot of. We go to all these conferences, we talk about it a lot. Lots of people also know about it. The lay person will know about it too. We often hear, I've torn my cruciate ligament. We can hear that on the TV. We can hear it talking to people in the coffee shops as well. So it's prevalent everywhere. And indeed, the studies do suggest it's up to 5% of all the time loss injuries within soccer, with an annual prevalence ranging between 0.6%, but even as high as 8% in some studies in males, and we know it's higher even still in females. There's a good study from the NCAA in North America quantifying it as 15 per 10,000 athletic exposures as a rate, and within the NFL 219 were described in a paper that looked at 4 seasons of play, which works out about 55 per year. So it's definitely something that we see a lot of in the elite athlete. In my practice, I see about 10% of my ACL cases are what we call elite athletes, and that's partly due to the National Health Service system in the UK. So some top tips about the consultation. It's a very different type of consultation to your normal clinic. I can be sitting in a fracture clinic in Bury Hospital on a Tuesday morning and a patient limps in having just torn their ACL over the weekend. I'd never met them before, I don't know their name. There's a good chance that I will know the elite athlete that comes into my clinic. I will certainly have known they've injured their knee beforehand, and they'll have contacted myself or my personal assistant to arrange the appointment, or their team will have done. And the key with all of this is that they don't really care about anything else. The sole purpose for them is to return to play as soon as possible. So in order to help that happen, we need to come up with a plan. It's a good idea, I think, to review the video of mechanism of injury, and that can give us some idea about some concomitant injuries that they may have in the same knee. Try and book an appointment when they see you with the MRI scan at the same time. That goes down quite well. We call that a one-stop appointment in the UK. And at the time of the consultation, have in mind the date of the surgery that you're going to offer. It looks very professional and it looks organised, and that transcends across to the patient and the player in this case. But it is a very stressful environment. There's lots and lots of questions, and there's not always a lot of listening to your answers. Raheem here listens a lot more, thankfully. And you can have loads of people in the consultation as well. It's not just you and the patient, like most of your consultations. You've got the player, obviously. You've got their coach, possibly a coach from the team, possibly a personal coach as well. Similarly, you've got a physio from the team, possibly a personal physio in addition to.
the agent, who's often the most vociferous person in the room. You've got their family, that could be the mother, the wife, brother, cousins. You can have an interpreter because, you know, that's often good. And there was even one instance where I've had an ex-wife come along because she wanted to make sure the income was still going to continue for her and the family. So, about planning a date for surgery. Well, is surgery indicated for everyone? Or is there ever a chance for non-operative treatment? That kind of could depend on the sport. There's a slight vogue for a trial of new type of bracing as demonstrated here. And there's a theory that modern bracing for an isolated posterolateral bundle tear might suffice. In one of the studies I was referring to earlier, they went on to show that over 76% went on to have surgery, but it's to be honest, closer to 100% in the elite athlete in my experience, although that is heavily influenced by the sport that we tend to deal with in soccer. I show this slide because this is a New Zealand rugby player, an All Black, as they are called, the elite of the elite in rugby union. And this gentleman, a chap called Tano Umaga, does not have an ACL in either of his knees, and yet he was able to play for the All Blacks at an incredibly high level for many years. That being said, you want to time the surgery appropriately, and that's a negotiation between you and the patient. You can advise, but they will have factors that influence the timing. It may be that their contract is about to expire. It may be that they've got a renewal of a contract coming up that influences the timing. It may be that they're about to retire and therefore surgery may not be an option for them, or it may be that a very important tournament is on the horizon for them. And these are all factors that play into the timing of the surgery. It's good to be versatile with your graft choice because there'll be some sports in which a hamstring graft is not appropriate. Similarly, there'll be some a patella tendon is not appropriate. There'll be some where, although we try to avoid it, an allograft may actually be the preferred choice. Or even, controversially, a hybrid between an autograft and a synthetic graft. Again, that's important depending upon timing of surgery, external factors, and the sport of the player. Whatever it is, though, I'd strongly advise being consistent with your own principles in terms of timing of the surgery. If you are happy operating in the first couple of days, then that's fine, go ahead. If, however, you like to wait, get the knee quiet, avoid arthrofibrosis, and if you do that for the general population, be no different with the elite athlete. Stick to your principles, because arthrofibrosis is a disaster for these patients, just like it is with everyone else. A lot of this talk is talking about be prepared, have a plan, and be as prepared as you can be for any other eventualities. When the patient comes to see you, they probably have already had a scan somewhere. If they haven't, you arrange one, but they probably know they've torn their ACL, and there's a lot of focus on ACL, ACL, ACL. It's our role to still take a history, still examine the patient, and still exclude any other pathology. And as I mentioned earlier, this is where the video analysis is very useful. Virtually all elite athletes now, at a time of injury, will be videoed, so it's fairly easy to get hold of those video analyses, and I'd strongly recommend looking at them. We should look for coexisting pathologies, one, to have the kit appropriately there for it, but then similarly, for something like a meniscal ramp or a root tear, it's useful to have the kit available anyway, because we may not actually see them until we're in there doing the operation. Now, about the operation itself, this is what we are good at. This is our bread and butter, to quote an English phrase. There's lots of external pressures when dealing with an elite athlete, but we do lots of ACL surgeries. This is our comfort zone, and this should be no different from what we do for anyone else. It's easy to say, hard to do, but in principle, this is no different. We have our plan surgically, we execute our plan, and it might be an idea previously to discuss with a colleague, discuss the scan with a radiologist physically in person to review the images, because a problem shared is often a problem halved, and it offsets a bit of that pressure, and you can concentrate on the job in hand to do the ACL reconstruction. In terms of results, you can't ask for a better cohort of patients. They're motivated, they've got the best physios in the country working with them, they've got the best facilities available to them day in, day out. And often the problem with them is holding them back, stopping them doing too much, than encouraging them to engage with their rehab. There's been some talk this morning about lateral extra-articular procedures. There's no evidence yet, to my knowledge, within the elite athlete as to whether they should or shouldn't be. There's growing evidence, and it may be that that emerges over time. But the trend has been for a lot of people to do something in the elite athletes, and this may be simply to leave no stone unturned. Personally, I'll do something in a very unstable individual's knee, or for a specific mechanism of injury, much like we see Zlatan here when he tore his ACL. So in summary, to finalise some top tips, you might be sitting at home watching the television when somebody tears their ACL. Expect the call, preempt the appointment, make sure you know your schedule, and have that all set and ready for when you receive that call. It looks professional, it looks organised, and it inspires confidence in your player and in the team around them. Have the appointment. If you can have the appointment and the scan at the same time, that's great, and have the theatre date available for them. Remember that you're going to be questioned, and you're going to be questioned like nothing else. It's reminiscent of the stress of the Viva examination in the FRCS for me, although it's a bit easier because I know more about the ACL than I did about certain paediatric conditions back then. Remember, you're the expert in this. You are the elite athlete of ACL surgery. They're coming to see you for your opinion. So stick to it. Stick to what you know. Expect the big entourage like we talked about. We need a big room. We need lots of chairs. Try and talk to as many people there as you can, but focus it on the patient. If someone talks about a second opinion, certainly don't dismiss it. I'd go so far as to say to even encourage it. Remember, these players talk to each other, more so now than ever. They're on the Instagram, they're on the Twitter, they're forever texting. They will know somebody who's torn their ACL, and they will ask them, what was your experience like? And they will compare, and you will be compared by them for your performance. The surgery is the comfort zone for us. We're happy there. Invite the physio to attend as well. They'll want to attend, they'll expect to attend, but it's like anything. If you invite them, it goes down a lot better than them having to ask. But most importantly, stay true. That's true to yourselves. Don't do anything that you're uncomfortable with. And similarly, true to the profession. We are professionals, we are surgeons. We have a code of conduct that we have to adhere to. And part of that is being realistic with the player. Don't offer them false hope. Don't offer any guarantees or promises, even if you feel that you're being negative. We do have to not get carried away with the emotion of sport, but remain stoical and professional throughout. So in summary, Mr. Chairman, ladies and gentlemen, ACL reconstruction in the elite athlete does seem glamorous to start with, but it is very time consuming and can be quite stressful. And at the end of the day, you end up with less gratitude than you might think you get going in, because ultimately there's always another surgeon that they can go to if they're not happy with something that you've done. And it tests your reputation like nothing else, particularly now in the world of social media. But as you can see, if you do love sport, it can give you the odd opportunity that's quite rewarding in life. All right. Thanks very much. Cheers.
Thank you, Dr. Neil, for this presentation. And we'd like to invite Dr. Fazal Ali, to be talking about ACL injuries in children, surgical technique and complications.
Thank you very much for inviting me here. I'm also here on behalf of BOSTA in the UK. 20 years ago, the incidence of ACL injuries in children was less than 1%. Now, if you look at ligament registries across the world, it's 5%. So the incidence is rising. Why is that so? Children are probably big in size, and as a result of that, if they fall, they get more serious injuries to their knees. They're more competitive now, and there are pressures on their sporting career. And on top of that, women are more involved in sports now. And we know that women have a high incidence of ACL injuries because of genetics, because of hormones, because of anatomy. and because of landing, neuromuscular. Also, we're looking for these ACLs. Our history is designed to picking it up. Our examination findings are designed to eliciting it. And MRI scans will help us even better now. 20 years ago, it was about 80% sensitivity of picking up an ACL rupture, whereas now a 3 Tesla MRI scan can give you a 98% sensitivity. But is this increased incidence really so? This study from the States shows ACL ruptures diagnosis between 2007 and 2011. There was a statistically significant increase in incidence in every age group except the adults. This is more so between the 10 to 14 age group and more so for females over males. Also, this study from out of New York shows the incidence of ACL reconstructions over a 20-year period. And if you age match that, you see the large peak here is due to 15-year-olds. Last month in the British Journal, Price et al. Published a 16,000 cohort of patients where they found there was a 29 times increase of ACL reconstructions in people under the age of 20 years old. So what happens if we do we do surgery on all these kids with an ACL rupture? In order to understand that, we have to understand the natural history of what happens. The only way to look at it is to look at conservative treatment. This study is the only paper that actually shows there was some benefit of conservative treatment over surgical treatment. All other studies show the benefit of surgical treatment. Why is that so? Because there is a up to 65% increase of meniscal tears in children who do not have ACL reconstructions. Most of these are lateral meniscal tears, but with time they become medial meniscal tears. And ultimately, what these kids end up with is osteoarthritis at the early age without treatment. So we know that surgery is the way forward for these kids. But in order to perform that surgery, you have to understand two things. Number one, what happens to the graft when you put it in to a child? And number two, what are the complications of doing your surgical procedure on a child? What happens to the graft? MRI studies will actually show that the graft increases in length as the child grows, but does not change in diameter. But what about the complications? If you look at the general complications for ACL reconstruction in a kid, they're very small. There are only two things that actually have significant consideration in terms of complications. One is re-rupture rate, and two is growth plate damage. What about re-rupture rate? There's a 3 to 4 times increase of re-rupture of the ACL graft compared to adults in any cohort, according to large studies worldwide. If you look at this and you compare it with the contralateral knee, 1 in 3 children who have an ACL reconstruction will either re-rupture that graft within 2 years or rupture the contralateral side. That's 5 times greater than the adult. So it's a serious consideration for these kids. What about growth plate damage? None of us want to see us operating on a child and ending up with a situation like this, where there's angular deformity or deformity of length. But does this really happen? Does growth plate damage really happen? MRI studies actually show, if you look 6 months after you've done your ACL reconstruction, that there's always some corticalization through the growth plate of this. But is it clinically significant? Peter Fano showed that every patient he operated on, there was some degree of growth plate damage, but none were clinically significant. Included, if you look at this cohort of patients from New York, over an 8-year period, there were only 4 patients who had a clinically significant growth plate damage. Meta-analysis of all the other studies showed low rates of growth plate damage. And if you look at the recent paper out, that I quoted that was published last month, over this 16,000 patients, the incidence of osteotomy or epiphysiodesis following ACL reconstruction is extremely low. Therefore, we're in a situation where we know we should do surgery because we want to prevent meniscal damage, and the chance of providing growth plate damage probably is not as high as we used to think. Therefore, we should do surgery in these patients. So what's the type of surgeries we do for these patients? There are three bit different actual groups of surgery. One is called transphysial, the physial sparing procedures, and a hybrid which is called the partial physial sparing. What about the transphysial techniques? This is basically the same operation you do on adult. So you harvest the hamstrings, you drill your hole in the femoral tunnel, you drill your tibial tunnel, you pass the graft through, and you secure it on either end with whichever method you feel. However, if you're doing a transphysial technique in a child, I want you to consider a few things. Consider using x-rays. Why is that so? Because you don't want your screw to cross the physis. If you're using a screw, consider using a bioabsorbable screw because you don't want a metal screw across the physis. If you're reaming, you don't want thermal damage to the growth plate, so you will consider reaming at a lesser speed. And you have to consider your drilling technique, your drilling direction, and also your graft choice. Let's look at the drilling. Animal models show that if you drill 3% of the growth plate, you get no problems with growth. However, if you drill 7 to 9% of the growth plate, you get growth-related problems. A 10 to 15-year-old child, an 8mm drill will only drill 2.5% of the growth plate. Therefore, an 8mm drill is okay through the growth plate. However, an 11mm drill will drill 7.9%. Therefore, you shouldn't go that big. The next consideration was the direction. Do we go in the standard position, which is about 45 degrees, or do we make the tunnel a little bit more vertical? Studies show that if you alter your angle slightly to go more vertical, it decreases from 45 degrees to 70 degrees angle by 25%, and therefore you can decrease the amount of growth plate damage you do just by changing the angle slightly. What about graft choice? Hamstrings autograft are probably the ones that we will go for. However, they're smaller in size in these kids. They'll have more re-rupture or contralateral rupture, so you may run out of graft. So think of using BTB, quadriceps, allograft, or parental graft. BTB is not really advocated because it has bone on either side, and that can predispose to premature fusion of the growth plate. Quadriceps is new and in vogue, and is probably a good alternative to use. Allograft is poor because it has a high re-rupture rate. And recently, parental graft has been coming in. Usually, paternal graft, that's the father, because the graft size is predictable, and you have no graft donation problems in the child. In some countries, they use maternal graft. The second procedure, apart from transphysial, are the physial sparing techniques, and there are two different ones: the extra-articular and the all-epiphyseal. I'll take you through the extra-articular procedure. This is one popularized by McKaylee and Coker in Boston Children's Hospital. This is the technique I use. It's a lateral incision towards the lower part of the femur, and then you identify the iliotibial band. You find anterior and posterior borders, and then you dissect it up proximally, and you may want to release it proximally by snipping the iliotibial band at that point. You then release it distally down to Gerdy's tubercle, and then you tubularize the graft. Then you do your arthroscopic part of the operation, and then laterally in over-the-top position, you put an angled clamp. And then you actually bring the tubularized graft through the over-the-top position and back into the joint and out through the anteromedial portal. Then you identify the intermeniscal part with a needle, make an incision, and then you draw it through the intermeniscal part of the joint. And then you fix it down to the tibia in extension. You close the extra-articular parts in flexion, but you tie the iliotibial band down to the tibia in extension. The all-epiphyseal reconstruction is a difficult operation technically to do, but what it does is it utilizes the anatomical landmarks similar to adult, but bypasses the growth plates. So essentially what you're doing is using an all-inside technique where you quadruple your hamstrings, and you, on the X-ray vision, you drill your femoral tunnels and your tibial tunnels, and you exit the same points in the joint that you would for an adult, but rather than transgressing the growth plate, you go in a different direction. The last technique is called the partial transphysial technique, which utilizes the fact that the distal femur has more growth than the proximal tibia. Therefore, you avoid the distal femur, but you can actually transgress the proximal tibia. And this technique is utilized in a certain age group, as I'll show you in a few minutes. So what do you do with these three techniques that we've just described? And in Sheffield Children's Hospital, we have a surgical strategy how we make our decision on how to operate on these kids. It's based on the symptoms of instability. It's based on the patient's activity and their goals. It's based on any other associated injuries, and then you also have to work out their skeletal age, and from that you use the Anderson Green chart to work out their growth remaining. Because it's your growth remaining that determines what type of operation you do. And this is our algorithm. Now, if you have a child who has an ACL rupture and has a meniscal tear, then that child needs surgery. And then you therefore do your ACL surgery that is specific for that age. If you, however, have no meniscal tear, then it depends on the growth remaining for that child. So if there are more than 5 years of growth remaining, then we advocate that we will probably try non-operative treatment with braces and so on. And if they can manage, they wait until about 10 years old, and we'll do a partial physical sparing procedure. If they, however, cannot manage, then we will do a physical sparing procedure with more than 5 years growth remaining. If they have 2 to 5 years growth remaining, then we'll do a partial physical sparing procedure. And if they have 1 to 2 years growth remaining, we will do a standard transphysial operation in those patients. Knowledge of this, I'll leave you with these three bits of information. Most of my knowledge comes out of the IOSC document which I think should be your gold standard of treating these patients, of which Professor Reider is part of. This article is from our team, our unit, in terms of ACL injuries in kids. And this book inspired me on the difficulties that kids go through with regards to their ACL injuries, and I'd urge you to read it because it's an inspiring book. Finally, I also would like to invite you to our conference that we do on the second international conference on kids knee injuries. The first was last year, the second is going to be next year in Sheffield in the UK, where it's a difficult treatment problem that we bring people together from around the world to discuss this problem. Thank you very much.
Do we have some questions from the audience? I have a question for Mr. Jain. First of all, you mentioned that you like to look at the injury video. What specifically do you look for in the video that helps you take care of the patient?
Yeah, good question. I mean, I may be wrong, I might be right. Certain mechanisms, I think, are associated with subtle differences with the ACL. And broadly speaking, maybe there's three. So there's the plant and the twist. There's the impact, lateral side.
Excuse me, Mr. Dear colleagues, if you are going out, be silent. We want to hear the answer of the question.
Thanks. That, I think, gives you an idea as to the impact of a medial structure going. And then finally, the other type that I've seen sometimes is where as we demonstrated in that picture with Zlatan Ibrahimovic, the Manchester United player, if there's a landing and a hyper-extension, slight varus type injury, those patients, when I test them for varus, I feel they're more opening up slightly, and it's that group that I will then go on and do a lateral extra-articular procedure as well for. So it's an added tool really in my decision-making process.
I have another question. In the U.S., I take care of American football and soccer players, and I've noted that soccer players are much less tolerant of any laxity in their MCL than American football players. I know you take care of rugby players and soccer or football players. Do you treat the MCL differently in a soccer player than you would in a rugby player, for example?
I do actually, yeah. That's very reassuring for me to hear that from someone like you as well, so that's good. It means I'm probably doing the right thing, so that's good. But yeah, it's interesting, and we haven't collaborated on this, I promise, but yeah, I think it may be an issue with the sport, it may be the physique of the individual, but I don't think the rugby players suffer as much from subtle MCL laxity as football. I wonder if it's soccer, I should say. And I wonder if it's that kind of dynamic valgus that they get into when they play. The other thing, of course, is the kicking mechanism. And we've got a player in the UK, England, called David Beckham, and there was a movie about him, To Bend It Like Beckham. So he popularised the technique of kicking the ball to get more swerve on it. And to do that, you often put a bit more strain on the MCL. So I think both are perhaps factors. But yeah, I'm a lot more aggressive with the MCL in a soccer player than I would be otherwise. Yeah.
We have a question. Mr. Jain. Do you ever make this dilemma of elite athlete or elite football player with meniscal injury, whether to repair or to excise because of timing?
That's a really good question. That's the staying true to your profession and true to yourself and sorry. Never mind. Oh no, I'm back on. So it's shared decision making. So I'm going to do my bit. I'm going to inform the player as much as I can. I'm going to be quite happy to say, your better long term is to do a meniscal repair, not a meniscectomy. There's good evidence in Andy Williams' group in London that compares medial and lateral side. So a lateral meniscus tear, meniscectomy, average career length afterwards is 3 and a bit years in soccer. Medial side, 7 or 8 years. So it's a lot more. So it's obviously we know the medial side is more tolerable than the lateral side, but it just stresses to me the importance of trying to repair. Now I'll explain it ad nauseum to the player. Ultimately, it's their decision, and I'll do what they choose, but I will push them. I'll try and encourage them to repair it. And repair. I think the English footballer, not being perhaps the cleverest guy in the school, they're becoming a lot more aware. There's more awareness of health and well-being generally in the UK, and that transcends to sport as well. Yes, you'll get an occasional player who might say, look, I've only got 6 months left in my career, I want to play in the World Cup, that's what I want to do it, fine. And you have that conversation. I've just had a similar conversation actually with a British Taekwondo player. It's a form of martial arts, and we're quite good at it in Britain, in the Olympic Games. And their concern is that if we did a repair, he's out of the Olympics. So we've actually left him to be treated non-operatively for the time being, but if he can't do what he needs to do, then we'll do a meniscectomy for him. But he's very intelligent, fully informed, and that's the informed consent process. But what I'd say about that is you've got to be true to yourself, and your duty is to your patient over the club, but primarily it's to the profession, and that's what I'd finish by saying. Yeah, thanks.
I have a question for my colleague here, Professor Maad. Although Systematic reviews seem to show the same rate of success between patellar tendon and hamstring reconstructions of the ACL. When we look at registry studies, specifically the Scandinavian registry and the Kaiser Permanente registry in the US, both of those showed higher failure rates in hamstring reconstructions compared with patellar tendon reconstructions. What's your interpretation of this, and does it ever make you nervous?
That makes us nervous. That I totally agree with you. This could be a problem that we have to face it sometimes. And everybody knows that the gold standard is the BTB because it's a bone tendon bone and it's wider, bigger. But right now we are trying to bypass it by increasing the size of the graft. Before they were doing just quadruple, just 4 strands. Now we are doing 6 strands of ACL, and it's almost equivalent to the length. When you compare the strength of both grafts, whether the BTB with the 12 strand or the 6 strands hamstring, they're almost equivalent in strength. The good advantage with bone is just the bone healing, but as well as right now, we are not putting screw, we are doing cortical fixation. So we are trying to approach almost the BTB with the hamstring. Now, what to do on whom to do this and whom to do that, I usually prefer to start every time with a hamstring graft and to keep my BTB as a plan B if there's any revision case. But I would start always with a hamstring.
Other questions from the audience?
Mr. Reider, after your presentation, your experience, if you are faced with a patient with ACL failure, mid-substance, will you recommend to do reconstruction or will you try repair first? Especially it's early.
Well, I can tell you, as I mentioned briefly, I worked with Dr. Marshall, and we did repairs on mid-substance tears all the time. And in fact, Martha Murray is doing repairs on mid-substance tears using her collagen sheath. However, at this point, until I have longer follow-up on those techniques, I would do a reconstruction on a mid-substance tear. Maybe in a few years, and we get 5-year follow-up from Dr. Murray, and she's still getting those good results, it would be time to rethink it. But at this point, we only have 2-year results, and her sheath is not released for general use anyway, at least in the United States. So I don't think I would do a primary repair on a mid-substance tear at this point in time.
Dr. Reider, from your experience, if you are faced with a top athlete, he's in mid-season, and he has a partial tear, maybe posterolateral bundle only, and end point 1+ Lachman, 1+ drawer, and he want to continue the season. What's your decision and what to say to him?
Well, first of all, I'm going to repeat the phrase you've already heard several times today, shared decision making, because ultimately we like the athlete to make the decision, although it's an informed decision, and obviously what the surgeon tells the athlete usually ends up pointing them in a certain direction. Although in this day and age where athletes read things on the internet and they get second and third and fourth opinions, they may disagree with what your opinion is. But to answer your question then, Professor, in general, it depends upon the sport. If they're in a situation where they're at the end of their career and it's their last chance to practice the sport, I will explain to them the risks, and I will say we will bring you along. If you choose to try to avoid surgery and return to your sport, we will go along with it. We will do intensive rehab. We will try to get you back, and if the knee starts giving out on you, then we recommend that you give up because you'll do further damage to the knee. I can tell you we've had some rare cases of success. We had one volleyball player. She was a university player, and it was her last season, and she wasn't going to be playing professionally. It was her last chance to play. And amazingly, she had a complete tear of her ACL. It wasn't a partial. She had a complete tear, and she was what they call a libero, which means she was going around doing digs and falling on the floor all the time and everything. And she returned and she did not have a re-injury. But that's, anecdotal one case. In general, for most sports, especially something like European football, we generally discourage them because the chances of re-injury are so poor.
Our president is saying that time. But immature, Ayman, we have immature children.
Yes. Questions for Mr. Ali, the last presentation, ACL in children. I have one question. You talked a little bit about parental graft, and I know Leo Pinchevsky and Justin Rowe, his younger partner, have written about this, and we've actually published papers in AJSM, which induced some controversy, I would say, and I felt a little bit courageous publishing that paper because I knew that a lot of Americans would think it was kind of ridiculous. But have you had any personal experience using parental grafts?
No personal experience. A couple of my friends do it in other places of the world. My personal experience, because we work in a Sheffield children's hospital, our problem is that anesthetizing the adult. So the parent, we don't have the ethical approval to anesthetize the adult in the next theatre to bring the graft across. So that's our problem in the children's hospital. Some of my friends who do this technique in India, they actually use maternal graft for their kids rather than paternal graft. The paper that was published by Pinchevsky was written by my ex-fellow also, and so my experience comes via that route. But it's something we're trying to work for. We think it's a way forward.
I think we have a question in the audience.
Obviously, the Isaiah sparing technique is not anatomical. So is it just to get the kid over a period of time, you will eventually need another procedure just to protect the knee? Will it work?
So Minkoko and Lyle McKelly just recently published, because they probably have the largest series. Their long-term results show that these kids don't end up going on for further revision surgery, and their revision rates is only just, if anything, only just slightly higher than would be expected for an adult cohort. So no, they don't necessarily go on for further procedures. If you're looking to do a more anatomical one, the all epiphyseal option is, but it's a difficult operation to do.
Another question. When you decide to change your strategy from conservative management into operative treatment in skeletally immature, especially 5 years below skeletal maturity?
So if you notice my algorithm, there's only one group of people, children, that we do not offer surgery, and those are the ones that are more than 5 years from skeletal maturity. So all other kids get offered an operation. So does that answer your question? We don't treat them conservatively, only the ones that are over 5 years of growth remaining. So if the patient remains symptomatic, or if you're that group that you're treating conservatively, if they remain symptomatic with instability, they can't perform their sport they want to do, or if they develop meniscal tears along the way, then we'll operate on that group.
So if you have 10 years kid with ACL plus medial ligament to the sternar lesion,
Okay, so we'll operate.
you will operate. Oh, yeah. Thank you.
What age do you think it's still a kid? You cannot, you say 15, is he a kid or is he a child? Or is he an adult? Which
So
technique do you operate on?
basically, 15-year-olds we treat as skeletally mature.
Skeletally mature, okay.
Yeah.
What if you have a younger than that, okay? Subepiphyseal, that's what I believe in actually, okay? That's what we were trained in France as well. Okay, to do below the epiphysis and try to preserve it as much as we can.
Yeah.
Do you think of reoperating on those patients later on in the future? Because it's not an anatomical ACL 100%.
So again, the data from those all epiphyseal procedures is only short term, because this
Exactly.
operation has only been around for less than 10 years. So these kids, we've only been doing them for 5 years. So this cohort of kids haven't been reoperated on, but that's a question that we may have to face in the future.
Thank you.
Dr. Saati, last question for Dr. Saati.
Thank you, Dr. Fazal, for your nice lecture. I'm just asking, is there still any place for primary ACL repair for skeletal immature, just to give him a chance or a stable knee, even if he has a failure after 3 or 5 years to do a formal or conventional ACL reconstruction later on? So is there a place for such
There is a place, and I in the 15 minutes I was allowed, I didn't actually present the work on repair within kids, but it has been tried by our center and other centers, but to be absolutely certain, the largest series is only about 10 patients. Mm-hmm. So we don't know the results of doing repair in kids. So it's being tried around, but there's still very small numbers as yet. But you have to do them within 6 weeks of injury.
6 weeks of injury, yes.
Yeah.
Right.
And and it's only the femoral pull-off,
Yes.
with,
Good-
from the distance,
with
from
good stump,
the femur.
yes.
Yeah.
Okay, thank you.
Thank you to all our speakers. Thank you to our audience, and please enjoy lunch. Shukran.